Let's discuss unintentional postoperative hypothermia implications in management. Today I want you to think about your patients. They arrive in the preoperative admission area and may look calm or they may look anxious, but in either case they will have heightened senses of anxiety and vulnerability. The patient has been taken out of their normal comfort zone and are often in an unfamiliar environment unless they've had surgery at your facility previously. Their sense of vulnerability and anxiety can increase as they lose control over their environment and step into the unknown. And one key component is that we ask our patients to change into a hospital gown in a cool room where they cannot control their own comfort. And this further compromises their sense of well-being. Listen to this patient quote, cited from a study on patient warmth and coldness in connection with surgery that was done in 2021. The patient says, "Then you feel as if you're wearing less. These big night shirts that are so airy. You feel naked even though you have something on you." And another quote, "There's a big difference in only getting this cotton blanket, partially because it's too thin in a way and it can't create heat." And another quote, "I froze so much. You know your teeth chatter, but you don't want to intrude either." Then on the other hand, some patients are too hot. Here's a quote from Gustafson et al. And the patient is too hot in this circumstance. And they said, "I really awake a little. And then suddenly, oh God, hot, it's hot. And then I realize somehow what is wrong. It feels like something is wrong in my body somehow." So thinking about all those quotes, today I'm going to ask you to keep in mind the patient's sense of loss of control over their environment as we review unintentional postoperative hypothermia, the implications hypothermia has on patient well-being, and how we should most effectively meet the needs of the patient to improve patient satisfaction and patient outcomes. Inadvertent hypothermia occurs once core body temperatures fall below 98.6 Fahrenheit, which is 36 degrees Celsius, and this leads to widespread metabolic changes in the patient's body. Some of those changes include level of awareness, changes in cardiac function, increased oxygen consumption, and extended plasma half-life of medications. Often, there are harmful consequences such as increased cardiac events, increasing infection rates, and increased length of hospital stay. When a patient enters the surgical environment and goes under general anesthesia, the greatest core to peripheral redistribution of body heat occurs in the first hour, and it's very difficult to treat that loss intraoperatively. O'Connor states that 64% of patients are hypothermic 45 minutes after induction, even when we use forced air warming devices like our bear huggers. You can use a measuring tool called the rule of nines to assign value to body surface areas for burn victims, and we can also use that tool to determine heat loss for perioperative patients. As an example, procedures performed in lithotomy position can lose up to 37% of their body heat due to abdominal and leg exposure. And we use draping and sequential compression devices and bear huggers to help support the patient, but heat loss is still a concern. And sources estimate that 70% of all patients arrive in the PACU postoperative unit hypothermic. So it's important that we review the types of heat loss so that you gain a better understanding and learn to control some of those aspects, as well as reviewing how the body uses thermoregulation to control core body temperatures and diminish heat loss. Some of the risk factors that were identified by ASPAN, as well as AORN and perioperative CPD include having an ASA score of 3 to 5, and the higher the number is, the greater the risk for the patient. Burns, cardiovascular disease, children and the elderly populations, corticoadrenal insufficiency, general and regional anesthesia in combination, and hypothyroidism. Additional risk factors include low BMI or, on the alternate side of the spectrum, body weight extremes, low OR room temperatures, major operations or procedures with long duration, preoperative temperatures less than 96.8 degrees Fahrenheit, which is 36 Celsius, where preoperative warming is not possible due to the clinical urgency of the need for surgery. So when you think about the risk factors we've reviewed, it's easy to see that this encompasses a major portion of the patient population we serve. Each patient will require careful assessment, improved knowledge of the surgical process, and implementation of targeted interventions. The first type of heat loss is called convection. In our facility, we have positive pressure surgical suites with sealing airflow systems that circulate air through HEPA filtration 16 to 20 times an hour. The large volume of air helps remove pathogens by using the air to push contaminants away from the surgical zone. And while this is a good thing from an infection control perspective, unfortunately this can cause up to 30% heat loss for the patient when air currents pass over the skin and transmit body heat to the air. In the OR, we can use warmed fluids, cloth or bear hugger blankets to help with reduction of convection-based heat loss, and you have an additional advantage in the recovery room by using curtains to help deflect some of those currents. Next, let's review conduction heat loss. In conduction heat loss, there's a transfer of heat from the patient to a cooler object due to the temperature difference between the two surfaces. This is referred to as thermal transference. Some of the most common causes are cool sheets and foam devices that are used for positioning in surgery, and they will wick a small portion of heat from the patient to that object. We can again use warm blankets or bear huggers as well as warmed IV fluids to help patients compensate for this loss, which is approximately 5%. Evaporation heat loss is a much bigger concern in comparison to conduction, and it occurs when liquids transform into vapors. You can see from the diagram that this type of heat loss is approximately a 25% evaporation compared to conduction with a 5% loss. Respirations create a small amount of heat, and that can be controlled by humidified oxygen or gas sources. But skin preparations cannot be warmed due to degradation of the product, and that is a major source of evaporation heat loss. If we have open abdominal procedures, that can lead to as much as 50% heat loss from exposed bowel and abdominal cavity tissues. And again, we use warm irrigation fluids and draping to expose only what is necessary for procedures. Humidified gases are used as well, but unfortunately this is a major area of concern. Let's discuss how the body tries to control core body temperature. Some thermoregulation facts include the fact that peripheral tissues absorb and dissipate heat to protect core body temperatures in coordination with the spinal cord, brainstem, and hypothalamus. A patient's peripheral temperature is typically 5.0 to 7.0 Celsius cooler than the core, and that's due to constriction of blood vessels leading to those tissues. Body temperature is also lower at night compared to daytime and are marginally higher in women than in men, but as a rule, the hypothalamus works to maintain a narrow core temperature in the range of 96.06 to 96.6 Fahrenheit, which is 36.7 to 37 degrees Celsius. The diagram on the right does a really good job of showing how the body will use thermoregulation to shunt blood from the periphery into the core when a patient is cold, and then back out again in response to warmer patient temperatures to cool the body. The patient is awake and senses that they are cold. The body will use thermoregulation to reduce blood flow through blood vessel constriction and decrease sweating to protect the core. If a person is awake, they may attempt to add clothing or blanket layers or seek shelter. If that is not effective or possible, then a non-shivering thermogenesis will attempt to produce heat from brown adipose tissue. But while this helps infants, there's minimal impact for adults. Shivering may start next to generate heat, and studies indicate that there is as much as a 6-fold increase in core body temperature as a result when compared to resting temperature levels. On the other side of the equation, high body temperature will cause the hypothalamus to trigger cooling mechanisms such as sweating, increased respiration rates, and vasodilation, and the patient will want to shed clothing or seek cooling devices if they are alert. When a patient undergoes general anesthesia, they lose behavioral responses that allow them to have the ability to adjust clothing or blankets in response to their environment. Anesthesia gases, propofol, and opioids impair thermoregulatory control by changing how the brain responds to cooling by vasoconstriction and shivering. The elderly population is particularly vulnerable. In the first hours, known as phase 1 redistribution, there is a rapid 1.0 to 1.5 Celsius decline in core temperature as medications cause vasodilation that moves cold peripheral blood into the core circulation. A more gradual heat loss occurs in phase 2, known as the linear phase, as heat loss to the environment exceeds what the body's metabolism can produce. There's an estimated 15 to 40% reduction in the metabolic rate during anesthesia. And finally, phase 3, the plateau phase, begins when core temperature equals heat loss to the periphery and there's a stabilization of the body temperature. When an anesthesiologist gives a patient a nerve block, the patient loses the ability to vasoconstrict or shiver below the level of the block. So having the knowledge of the level of the block is an essential component of determining the risk of heat loss. When you combine a regional block with general anesthesia, that becomes more problematic. And if you have a diabetic patient with impaired neuropathy or vasoconstriction, the plateau phase where stabilization occurs may never be achieved. The body can compensate by causing some vasoconstriction above the level of the block, and some types of blocks actually produce more thermoregulatory impairment than others. But overall, studies indicate that the mechanism of action is truly not fully understood. Now that we've reviewed patient risk factors, the types of heat loss, thermoregulation, and the impact of anesthetics on hypothermia, let's take a look at some of the consequences of perioperative hypothermia, and once we're done, you'll realize how profound they can be for the patient. Perioperative CPD provided the following statistics. There's a 3 to 5-fold increase in the risk of surgical site infection formation, and that's due to decreased blood flow and oxygen delivery to tissues, decreased immune response, and action of the macrophages. There's decreased wound healing from loss of tissue perfusion and collagen synthesis. There's impaired drug metabolism in the liver, leading to long action of neuromuscular blocks, prolonged action of propofol and opiates, and double the action of vecuronium, which is a non-depolarizing neuromuscular agent used as a skeletal muscle paralytic, and that gives a profound hypothermia of 2 degrees Celsius. We see increased bleeding, coagulopathy problems, and subsequent transfusion requirements. And the clotting cascade is temperature dependent, so hypothermia also impairs the enzymatic and platelet function properties required for clotting. Additionally, there's increased rates of cardiac events from increased release of adrenaline, noradrenaline, and dopamine, and that leads to increased blood pressure and increased myocardial workload. To accurately determine core body temperature, we must optimize temperature collection data, so the devices we use should be a strong consideration. Infrared tympanic and temporal artery thermometers only give an indirect estimate of core temperature, and they're really not considered to be accurate. Ear readings can also be impacted by ear debris and do not reflect core temperature, so avoiding these devices in major surgical procedures is recommended. In the preoperative and postoperative areas, oral or axillary temperatures are recommended for alert pediatric patients. Oral temperature is recommended for alert adults as well, and nasal or deep forehead devices are considered to be the most accurate in the PACU. Rectal temperatures do correlate closely with core temperature, but can be impacted if your patient has hypovolemia. In the intraoperative phase, esophageal stethoscopes or Foley catheters with core temperature monitoring can be inserted in major procedures, and if either are left present in the PACU, can be used to monitor in that area as well. For regional procedures, nasal or deep forehead devices are the preferred choice. As you can see from the diagram provided by Periop CPD, patients who are not warmed will have cooler extremities, so the cooler blood will be shunted to the core during the redistribution phase of anesthesia. Nursing interventions that involve pre-warming can make a real difference in patient outcomes, as warm peripheral blood maintains core body temperature. ASPAN also provides clear evidence that supports the use of warmed blankets and passive warming devices like bear huggers on all patients. ASPAN provides the facts about warmed air, including using warm blankets and passive warming on all patients. And if a patient has a temperature less than 96.8 or 36 Celsius, they should have forced air initiated. Pre-warming patients for 30 minutes prior to surgery decreases intraoperative hypothermia exposure and increases patient comfort. Pre-warming for 20 to 30 minutes preoperatively decreases redistribution hypothermia. And they also recommend continuing forced air warming in all phases of care to maintain normal body temperatures. Active warming also minimizes shivering. So nurses should always document patient refusal for warming, as the evidence indicates that it should be used in all cases. Routine temperature assessment and monitoring with a device that is appropriate for the patient and the circumstances required in all phases of perioperative care. Consider the accessibility of the measurement site, patient comfort and safety, your ability to use the device, and device accuracy. Temperature must be measured every 15 minutes if the patient is hypothermic or when active warming devices are in use. Patients should not be transferred to phase 2 or to a nursing unit if hypothermia is present. The chart on the right contains data from ASPAN that clearly indicates that core temperature management will not be accurate when tympanic, temporal artery, or axillary measurements are taken. Those methods should be utilized for short-term cases with minimal risk of hypothermia. So let's review the temperature management devices that ASPAN covered. So oral thermometers are considered the most accurate non-invasive measure of core temperature as long as they are placed in the sublingual buccal pocket. Even in the presence of oxygen therapy or with respiratory breathing that is oral or varied, it can be the most accurate. There's a newer device called zero heat flux thermometry, and so it is a probe that's placed with a patch on the forehead, and it accurately mimics pulmonary artery catheter temperatures and esophageal probe temperatures. Temporal artery thermometry, again, can be comparable to core temperature in adults, but there is data that says it's similar to tympanic, and there's a real lack of evidence to support its accuracy. Axillary temperatures, very important to note that that is not an accurate measurement in a febrile or hypothermic case, as it can be variable and it often underestimates core temperature. Bladder temperatures are very accurate but can be subject to what's called thermal lag if there's an unsteady thermal state for the patient. So if their body temperature is hypothermic and it's fluctuating, it's not going to necessarily be as accurate, but it is a useful indicator of body warming as long as there's continuous urine drainage. Rectal temperatures, again, they can also be subject to thermal lag if there's an unsteady thermal state. However, the probe has the propensity to be in contact with stool, and that can cause some levels of inaccuracy. So as we wrap things up for this module on unintentional hypothermia in the perioperative area, please keep in mind that any body temperature that falls below 96.8 is considered hypothermic, and there can be widespread metabolic changes for your patient. It's important to use risk stratification and accurate assessment of the patient's body temperature to determine what types of warming we need to implement so that we can promote optimal patient outcomes. Thank you for completing the module on unintentional postoperative hypothermia management. If you're a Rose employee, please complete the post-test and begin to implement measures, if you've not done so already, that will help support maintenance of core body temperatures. Have a great day.